It's an honor to be here. As you know, obesity is not just a woman's disease, it affects males as well. I have to stand up in the male part. However, there's two interesting points. One is there are certain ethnic and racial groups among women, lower socioeconomic groups, African Americans and Mexican Americans particularly, have a very high prevalence of obesity, particularly severe obesity. So you're more likely to see the severest forms of obesity in some of your patients, depending upon the patient population you treat. The other is that about 75% of programs for weight control are women. And when we do clinical trials for weight management, whether it's dietary trials or pharmacologic trials, we have to specially recruit men in order to participate. So the take-home message, I think, for clinicians is that women often come in more activated and engaged, wanting to take care of their weight or control their weight. Men, you have to probably convince a little bit and motivate and be an agent of change and so forth. So it's certainly very appropriate that we're talking about obesity. These are my disclosures. I'm an author of several books and I get royalties from them. That's why I put that out there. So obesity is a complex, multifaceted, chronic relapsing condition. And to add insult to that, we are trying to primarily treat a public health problem in the clinic. So it's really daunting. So it's no wonder that patients come in really frustrated and angry and defeated. You know, how many times have I been at this? And they have this fatalist and futile attitude. And of course, it affects us as caregivers, as providers. We get frustrated because the patient is unable to either take weight off or keep the weight off. Well, it's very difficult. It's daunting. And there's multiple determinants of obesity. There's not likely ever to be one silver bullet or one treatment that will either put obesity into remission or frankly cure it, including obesity surgery. So we need to keep in mind all of these determinants when we are treating patients. The one I want to point out, which has really led us down the wrong path from multiple stakeholders, and certainly from the way people in our society consider obesity, is they think of it only as a personal responsibility. In fact, most of the paradigms for obesity care to this time have been one of personal responsibility. Just push yourself away from the table, don't eat so much, what's wrong with you? A lot in government see it purely as personal responsibility. It doesn't affect me, I'm going to eat what I want, don't take my food away. You know, if I don't want to do anything, that's my business, it's your problem, you take care of it. And obesity is anything but only personal responsibility. Yes, it incorporates that, but we really need to think in terms of environment and the built environment and genetics and ecology, which means as I'm going up here and I'm watching everyone standing on the escalator, not walking the escalator, but standing on the escalator so it moves your body up. Okay, that's ecology. Everyone's doing it, so I'm going to do it. And so it's difficult to swim against the stream. You have to push everyone ahead of you. Walk, walk, walk. In fact, after this talk, at the next break, I'm interested to see how many will walk up the escalator rather than having to move your body up to the second floor. Anyway, we need to keep all of this in mind. So obesity affects women according to different stages of the life cycle. And I put this story together regarding etiology, and I think etiology informs us regarding treatment. Thinking in terms of the life events of a woman, child, adolescence, and furthermore as a woman ages, of what is really causing weight gain, and that specific life event in part will inform us and guide us about what kinds of treatments we want to offer. And I'd like to tell the story of life events from patients themselves. So in my program, this is probably a decade ago I've been doing this and written about it as well, is I asked all of my patients in a pre-visit questionnaire to fill out a form, which takes about 10 minutes. But in that form is this graph. And at the very top it says, I would like you to draw your weight according to life events from any time you'd like to start and go all the way to the present. And this is really what I give them. It is probably the most informative, therapeutic, and reflective exercise I ask patients to do before I even walk into the room and say anything. So this is drawn by a girl who came in summer break from college. This is her memory, her recollection of how life events affected her weight. Started high school, felt good about life, lost a little weight, she was in 10th grade. gained weight, and then broke up with a new relationship. Getting ready for prom, she took a little bit of her weight off and then entered college and had the college 10 or college 15 or whatever. Whether this is true or not, I don't know, but it really doesn't matter. It's what the patient is telling me. It's her reality. And the etiology of childhood and adolescent obesity is becoming clear. Again, there's no silver bullet. If we take soda cans out of the school, that alone will not take care of childhood obesity. Not that it isn't a good thing to do, but they're going to walk 100 feet to the 7-Eleven and get soda. It's the environment that you have to look at. But these are the factors that have become very clear. Screen time, which is inactivity or sedentary activity, as well as the prompts that they're getting from watching television, as well as computer games and so on. Dr. Lindsay talked about how the kids, that were 10-year-old, I think, but wasn't getting vitamin D because they were indoor playing video games and computers, and that's exactly right. Less exercise time during school because of the cutbacks, less wellness or kinetic wellness. Liquid calories, which is soda and juices, and Dr. Lindsay actually showed the inverse between milk and sodas, and that's absolutely true. More meals eaten away from home, which continues to skyrocket. Snacking in between meals, snacking when you get home from school. And lastly, which I think is becoming very apparent, is parenting and role modeling. I don't do pediatrics, I'm an internist, but I am talking about parenting and role modeling every day in my practice because it is a family affair. So if you want to talk about treatments of children, it's the inverse of everything that I just told you. So these are the topics you need to be having a conversation with the parent and with the child to get them outside to be more active, to reduce inactivity, and think about healthy snacks in the home and role modeling in the home. Supersize America, this is just an image I put up here. It's very clear that we have distortion of all of our portions. So if anyone who travels abroad knows and comes back to the United States, it's a mess. The calorie size, the unit dosing of food is made for the largest man you could think of, and they serve that dose to everyone when you go to a restaurant. They don't ask what your weight is, what your age is, where your medical problems are, and they feed you calorically depending upon what you eat. No, you eat what's in front of you, and that's a real problem. To Michelle Obama's credit, she is, her thing is childhood obesity, the Let's Move campaign, as you're all familiar with. So she is taking this on as a public health issue, very appropriately. And childhood obesity is kind of a safe haven. Who's going to say no to childhood obesity? Her goal is more about prevention of obesity, and that doesn't necessarily help the kids in our office today who are obese, but there's spillover effect. Obviously, the efforts that we put toward for prevention have an effect towards treatment as well. And to her credit, it wasn't just a veneer, it wasn't just, this is my, just say no like Nancy Reagan, or let's just treat obesity and move on. She actually convened a White House forum and put national objectives with metrics in place regarding what all these stakeholders should be accomplishing over the next decade or so. This could be found on Google for those of you who are interested in it. The one interesting thing, or one important thing about childhood obesity, though, is the whole idea of stigmatization and the role modeling that we have. Many of you remember billboards, with regarding HIV and hepatitis C and so on, and you could have national campaigns, safe sex and so on. Very difficult to have national campaigns for obesity because of all of the mixed messages that kids have. So we have to be very, very careful when we're talking to our children about these mixed messages, and particularly the body shape, which young girls are really attuned to, whether they're getting from mother, those images, or from media. I don't know, and stigmatization of obesity is extremely something, again, we have to be careful. If you just do Google image and put in childhood obesity, these are the things that start popping up. And these are the images you see that are used on the B-rolls all the time when national stations have an obesity story. These two people are very famous because of they're used constantly. This was a billboard campaign in Georgia. I don't know how many of you are familiar with this. This was a firestorm of criticism. Some people thought this really was stigmatizing. They're really putting these kids out. You can imagine what it's like when these kids go back to their school and what kind of bullying may have actually occurred. So this is an attempt at at social marketing to try to get attention of obesity. You may think it's good, some people think it's offensive, but again, it's a very difficult thing to get the message out about childhood obesity. It has to be done in a very, very sensitive way. As the adolescent female goes through puberty and goes through childbearing ages, obesity certainly has an effect on menstrual cycle irregularity and ovulatory infertility. They both increase with increasing BMI because of hormonal changes with the fat tissue itself, or PCOS, so that's something else you need to be thinking of. But if the woman who is overweight does get pregnant, this is really what the life story often looks like. Here's the college 10, lost a little weight through diet and exercise, got married, and then had two biological reasons where she gained quite a bit of body weight, lost weight in between, but by the time of her second pregnancy, she weighed even more, and then had a psychosocial problem at the end called job demotion. Here's another woman in college, she maintained her weight, but her stressful job caused her to gain weight, and then birth of multiple children caused her to gain further weight. And here's baby 1, baby 2, baby 3, baby 4, baby 5, and my response is, have you had enough already? So she came to me saying, okay, now I'm ready to lose weight. So she's talking about women in their 20s and 30s, this is really a time that we have to pay more attention. Now this is, in my own career, which is now spans 30 years, this was a time in life that I really didn't engage the woman with as much. For the longest time, during pregnancy, we didn't want a woman to diet or change their diet or lose weight or, just kind of watch yourself. But after you have your baby, come back and then we'll work on healthy lifestyle and so on. And that's changed dramatically. We now have, this is a feudal area, not feudal, it's a very exciting area of research, which is controlling body weight during pregnancy. At Northwestern, we developed a program, very clever, called Healthy for You, Healthy for Two, and it's specifically designed for women who are overweight or obese going into pregnancy or had past bariatric surgery or had gained a lot of weight in a previous pregnancy, and it puts her at higher risk, or a woman who's of older age. So the reasons for that are many. Certainly postpartum retention. As I've already showed you, when a woman is pregnant, she's more likely to gain more weight, and that would be successive weight gain. Obstetric complications that many of you are aware of. Problems through birth as well. And the last is actually the most concerning, and actually dovetails very nicely with the talk we just heard, which is called fetal imprinting or epigenetic effects of the woman on the fetus regarding the increased risk of obesity, metabolic syndrome, cardiovascular disease, and diabetes. We know women with gestational diabetes are more likely to be overweight, perhaps through increased fuel or through increased glucose through the placenta. The child is likely to be more obese and have diabetes him or herself. So interesting, I started with postpartum retention, so the woman may be getting more obese, and that obese woman is more likely to have obese offspring, so you have this vicious circle of a woman who's overweight or gains excessive amount of weight during pregnancy, giving birth to a child who already is vulnerable to be obese him or herself. So it's a feed-forward mechanism going in the wrong direction, and that is a fatter and heavier population. So this is just some data that shows that if you look at maternal BMI, which is on the left, and then you look at the percent of the offspring who are obese at age 2 years old, 3 years old, and 4 years old, you see the heavier the BMI of the mother, the higher the prevalence of obesity in the offspring, which has to do with this imprinting phenomenon. Now, part of it may be what's going on in the home, parenting, and so on, but it's in large part genetic as well. So what we want to do in a woman of childbearing age, particularly one who's pregnant, is to intervene, which is something we never used to do, but intervene pre-pregnancy or prenatally as well as during the pregnancy, and try to hold the weight gain to a healthy level. This is data that came from the IOM, published in 2009. It's the very first time that the IOM came up with a weight limit for women who are obese. That is, if your patient is pregnant and has a BMI of over 30, for the very first time, a healthy body weight range has been suggested of 11 to 20 pounds in less obese or healthy weight. Of course, or up to 35-pound weight gain. To this point, there has been no successful program that has been published in intervening in women with obesity and pregnancy. It appears to be more effective in a woman who's less obese. Well, if you take a woman with a BMI 35 or 40, there's really no study that has been shown and certainly not been reproduced to be effective. So it's really a very difficult challenge to intervene in this patient population. But the rewards are tremendous based on what's happening with the offspring and the pregnancy complications. Of course, we have an obesity family, and the mother is growing older. Now we have what is going on in midlife. So there's much more written on here. In the very back, it's hard probably to read it. So it starts off with college, marriage and kids, college, poor marriage, quit smoking. There's another cause to gain weight. You got a divorce, you got a new job, you got living alone, you got, at the end it ends up with promotion to VP, one of the happiest things in life, and the trajectory of her weight actually takes off, which has to do really with less time for herself, devoting more time to others and so forth. Here's another one which you've seen many, many times, childhood weight gain, and then this cycling of the weight through college diet, Weight Watchers, Jenny Craig, Phentermine, and then she's coming in to see me. So are these commercial programs actually worth referring patients to, or are you likely just to get this cycling? Well, there's been 2 studies that have now been published recently, peer-reviewed journals, randomized controlled trials. This one is Jenny Craig, the next one I'm going to show you is Weight Watchers, that actually show these commercial programs are effective, at least over the short term, in causing more weight than someone who's randomized to usual care. This is a 2-year study published in JAMA showing that those that were randomized to Jenny Craig, which means consuming pre-prepared portion-controlled food, actually lost more weight at 12 months and kept more weight off after 24 months, upwards to 8 to 12% body weight. This data came out more recently in Lancet, which is the Weight Watchers randomized controlled trial. It's a standard, it's done in Europe. Standard care, which means they're seeing their primary care physician, or they're randomized to Weight Watchers, and here they're losing about 5% or 6% of their body weight. The summary, which was just actually published in circulation by Tom Watten's group, is that if commercial programs indeed are effective for at least short-term weight loss and may be a viable option for those who cannot obtain treatment by traditional lifestyle modification. The problem is that maintenance, or what we call long-term weight maintenance, is very, very difficult, not only just for women, but for everyone who's struggling with their weight. The reference got lost on here, but it's from International Journal of Obesity over the past 2 years. And this is NHANES data, so it's questionnaire data. In asking 14,000 participants from NHANES, how many of you have been able to keep off your weight for more than a year? Turns out about a third of Americans are able to keep off past a year about 5% of their body weight, and it really dwindles after that. Only 17% are able to keep off 10% of their weight, 8%, 15%, and less than 5% are able to keep off 20% of their weight for more than 1 year. So it's not that these programs don't work. The problem is that no program seems to work long-term other than bariatric surgery, and that's really where the challenge lies, is building the skills behaviorally and perhaps matching the pharmacotherapy and understanding more the complexity of biology to combat the adaptation that occurs metabolically. I want to get back to the effects of obesity in women of middle age. This is data from 7,000 women looking at quality of life issues. So on the left, we're looking at women with a healthy BMI of less than 25, and on the right, women who are obese, BMI 30 or more. And these are the daily quality of life issues that women are going to be talking about. And you can look at the difference in the prevalence between healthy weight women and women with obesity when it comes to shortness of breath, walking up the stairs, chronic low back pain, and how they measure their actual quality of life, walking one block, bending, and so on. So you can imagine, if you're working with a woman who is a BMI 35, you said, I want you to go up there and start walking quickly, I want you to climb the stairs and so on, you got to realize that they're short of breath, they have aches and pains, it's hard to bend over, and you're going to get a lot of resistance. Not because I don't think they know what to do, it's hard, and that's the burden of obesity. We also know that the chronic illnesses that you're treating every day because of the need to treat these diseases increase as BMI classifications increase. This is older data, but also from Haynes. And you look at the prevalence of type 2 diabetes, gallbladder disease, coronary heart disease, high blood cholesterol, blood pressure, and osteoporosis, pretty much in a dose-related manner increase as the BMI classes continue to climb. Look at hypertension. Over 50% have hypertension once you get to a BMI class 2, which is a BMI 35 or more. Diabetes, you've heard about many, many times. And on the x-axis, you have increasing BMI. On the y-axis, age-adjusted relative risk. When you're looking at men versus women, the relative risk of getting diabetes really explodes in women, much, much greater than in men. This dotted line is a BMI of 30. So what does it say? As a woman has a BMI of 30, which is oftentimes when a doctor maybe starts to pay attention to the woman's weight, she already has almost a 28-fold increased risk of getting diabetes. This is from the Women's Health Initiative, the Nurses' Health Study. And the other dotted line is a BMI 25. So this is a woman who's just crossing into overweight, probably not paying much attention to her weight as far as counseling. She already has an 8-fold increased risk of having diabetes, at least from the Nurses' Health Study. Waist circumference, you've heard much about. This is also from the Nurses' Health Study. You're looking at increasing waist circumference on the x-axis, relative risk on the y-axis, and you see, again, a nice kind of dose response. The more a woman has increased upper body segment obesity, the greater the risk of developing diabetes. So when we kind of think of it is, if obesity is in the car and is driving, in the rear view mirror is diabetes. I mean, it's just right there, and they really go hand in glove. You need to be screening your patients, of course, for fasting glucose or hemoglobin A1C in a woman or a man who's obese. So I just want to say a little bit about abdominal obesity, because we're going to be getting into menopause soon, as far as the life events. And it is all about abdominal obesity, where the action seems to be, or the culprit fat depot is primarily in the abdominal cavity. This is Haynes data again, looking at changes in BMI and waist circumference among women. So this is secular data. It's not, each of the years you're doing prevalence data. But what you're seeing in America is a progressive increase in BMI from the mid-70s all the way to about 2005. And here you see the racial ethnic differences I was mentioning before. So black females have higher BMIs as well as higher waist circumferences than the other ethnic groups. All ships are rising, if you will, from a secular point of view, but some individual and some groups have a higher prevalence. So it's not the pinch and inch that we need to be thinking about in our patients. It's really what's going on in the inside, which is the visceral fat. So this is data from menopause. This is, I'd say, the most challenging patient I see in my practice. I run a center for lifestyle medicine, so it's all about the power of lifestyle. How could you take care of yourself? The most challenging patient I see is the perimenopausal woman, because it's a scenario something like this. Someone took over my body. This is not me. I look in the mirror. I don't know who's staring back at me. This is not the figure I've had my entire life, and I am mad as hell. And no matter what I do, I can't seem to change it. And my first question often is, from a biological point of view, are you starting to look like your mother? I don't mean it in a derogatory sense. And typically they'll say yes, and I promise I've never turned into my mother. And that's the reason I say that to the woman is that it's the beginning of, not to be smart, but to be the beginning of a conversation of biology, because it really is the biological differences. This is a study done by Jennifer Lovejoy. It's a very nice longitudinal study in a cohort of women, and there's a lot to learn from this. I'll just walk you through this. What she did is a variety of measurements on body composition, energy expenditure, and hormonal levels in a cohort of women starting 4 years before menopause. Then through menopause is what you see the arrow, and then post-menopause. And what you see is the body weight starts to climb at T-2, T-1, and then at 0 is menopause. You've already gained some of that weight. If you look at body fat, it starts to climb before menopause. So menopause is an absence of a menstrual cycle for a year, so that's time 0. So she put the clock back, so body fat is starting to climb. Visceral fat declines dramatically, which is in the lower left. Starts to decline before menopause, and then the subcutaneous fat climbs, but not as much as the saturated fat. From a hormonal point of view, estradiol, as you would expect from the upper left, is starting to decline at time zero. Menopause is already very, very low. FSH is climbing, inversely. In the bottom two panels is the most important regarding mechanisms of action from the body, about actually what's happening from an energetic point of view. On the bottom left, it says activity by triaxial accelerometer, which means body movement. And what it shows is that starting at about 2 years before menopause, physical activity, as measured by wearing an accelerometer, starts to drop. In menopause, it's just about the lowest. And then it starts to climb a little bit after menopause, probably volitionally, because the woman is starting to be concerned about her weight. So physical activity starts to climb. Total energy expenditure, which is the bottom right, also starts to decline right before menopause, and then remains the same or starts to go up a little bit. So the bottom line is, data from this and other studies suggest that the changes that occur during menopause are biologically driven. That's very clear here. Women start to gain increased abdominal fat, which is visceral fat, which leads to metabolic syndrome abnormalities, changing LDL, glucose intolerance, and so forth. And physical activity starts to fall. Now, why physical activity starts to fall is not entirely clear. That could be in part life events. Spending, maybe the woman's getting out of the workplace at that time, or spending more time at home, or more leisure time, more availability of activities that don't require as much physical activity. It's not entirely clear, but we use that kind of information in order to guide our treatment for that individual. So when I see a woman who is perimenopausal or postmenopausal, yes, we're talking about pay attention to your diet, track your diet, telling them they probably don't need as many calories as they used to when they were younger, and that's a revelation for many individuals. You don't need as many calories. And specifically, increasing physical activity, and among the portfolio of physical activity, resistance training. Because you really want to maintain lean body mass, and increase lean body mass, increase metabolic rate, and that in part increase energy expenditure. So the conversation we're having with this type of woman is, yes, you have to track your diet, you have to be calorically conscious, you have to think about a nutritionally balanced diet, but really increase your physical activity, particularly resistance training. Now, how much physical activity is needed across the life cycle, but particularly in this age range, there's a lot. The data comes from, summary data comes from Dietary Guidelines of American 2000 report of the advisory committee, as well as the physical activity for Americans 2008. And this is what all the studies show. There's clear, consistent research that shows that a large amount of physical activity is needed for substantial weight loss and or to keep that weight off. So we're really talking about not the 150 minutes a week, which you heard about earlier from the Physical Activity 2008 guidelines. You're probably talking more like 300 minutes a week of moderately vigorous activity. And the data from the Women's Health Initiative shows that that kind of activity stalls the weight gain that's going to occur. It doesn't prevent the weight gain, it just slows the trajectory of the weight gain occurs. So biologically, it's very, very difficult, not impossible, but I find it very helpful to have a frank and honest conversation with individuals. Otherwise, they think it's their fault. There's something wrong with them. So education helps, and strategies to accomplish this helps. I'm just going to skip over this if I can. Just one other point about the increased health concerns in a woman at this age is increased GERD, among many, many things that are occurring. So if you have your woman coming in with GERD and increased abdominal obesity, and one of those treatments is going to be weight loss, as well as all the things you do, don't eat late at night, and so forth. Cancer, there's been many talks on cancer, and I just wanted to just kind of summarize or emphasize for you that there is a association of obesity with multiple cancers. The one that is the largest is uterine cancer. As you know, the more obese a woman is, and particularly depending upon their access to care and affordability, they may not be getting any gynecologic care at all, either because of shame, embarrassment, or they just choose not to have that exam. To summarize the current treatments of obesity, Diet, exercise, and behavioral therapy continue to be mainstays of obesity treatment. It really does depend upon the life cycle of the woman, of what you're going to be emphasizing in a child. It's really increased playtime, reduced sedentary time, healthy snacking, role modeling, doing family affairs, taking your overweight dog in the family and walking that dog as well. I didn't say much about pharmacotherapy. I can talk about that during the Q&A. There really is nothing much to talk about pharmacotherapy. That's why it's one bullet point. There's one drug that I think will be approved by the FDA in April, which is a combination of topiramate and phentermine, which is called Qnexa. It got a 20-2 positive vote from the advisory committee. If that's true, that will be the very first anti-obesity drug approved in this country since 1999. That was the last time there's an orlistat that was approved. A 5 to 10% weight loss improves many of the obesity-related metabolic problems. I think we're pretty good at helping individuals lose weight. The challenge is weight maintenance, as I talked about earlier. Active weight loss maintenance requires long-term support of resources. Just one word about the actual diet that we do during Q&A if you want. The primary driver of weight control and obesity is calories, period. That is the economy of body weight, is caloric intake versus caloric expenditure. So if you have a 2-minute drill with someone about obesity, don't start talking about carbohydrates and the fats and all that. Talk about calories. Have them record their diet, track their diet, use an internet program. They're all free now, so they're good ones. And have them track their diet, record what they're eating, give them a caloric content or a caloric goal to shoot for. Now, having said that, because that's the first thing you want to do, then the kind of diet you want to recommend does depend upon the metabolic abnormalities that you're trying to treat. So if someone has hypertension and obesity, using the DASH diet, or either getting it off the internet or talking about DASH diet, really has the best evidence for it. When it comes to increased blood sugar, carbohydrate control diet, if it's other components of metabolic syndrome like dyslipidemia, either the Mediterranean diet has very good evidence for it, or the therapeutic lifestyle change or TLC diet. So that's nuances, but number one, first and foremost, is caloric control. And just one last slide on the difference between what we're trying to do regarding weight loss and physical activity. Physical activity alone is not a very effective means to lose weight. That's an important caveat to take home. The story goes like this. Doc, I'm really frustrated. I've been going to the gym 3 days a week on the treadmill for 35 minutes, at a rate of 3.5 for the past 6 months, and I haven't lost more than 2 pounds. What's wrong with me? And the bottom line is that exercise is not a very effective means to lose weight. You can't burn enough calories off to really make the difference. You can make it up with one cookie, well, everything you just burned off. And it's hard to get that balance. So it's very important that we tell them that physical activity and exercise is a very important component of weight control. It's the other side of the coin. However, it is not effective by itself to lose weight. But exercise independently will improve the comorbidities that we're trying to treat, including diabetes, type 2 hypertension, coronary disease, osteoporosis, and so on. So physical activity is an important component, but it's not the primary component that someone's going to be able to take their weight off. So in summary, there's multiple events in a woman's life that predisposes her to gain weight. The reasons for weight gain at each time point differ. A combination of changing biology, hormonal status, and life events really is what is the cause for that. And that should inform us, indeed, what we're doing. It's important to implement preventive and treatment strategies to help further weight gain in the development of ill health. Thank you very much. I'm happy to take any questions. Let me start there, and that way I can just walk the floor across that way.
All right. Question for you: the mechanism of action of the Qnexa weight loss drug and dosing.
So currently, phentermine and